Hey, what's going on, guys? My name's Tom. I am an incoming PGY1 anesthesia resident, and for the past year, since taking Step 2 and scoring over a 260, I have been tutoring with various companies for both USMLE Step 1 and Step 2, as well as Comlex Level 1 and 2. Number one thing I've noticed along the way and in this process is that there is no good review resource for studying for this exam. And so I think I just wanted to put something out that's cheap, that's easy for you guys to use, and that also provides good information. Over my time tutoring, I've had to create my own resources to tutor off of, and I've gotten good feedback that these are very helpful. This is all stuff that has been written by me personally, and it's not content that I've taken from any question bank or any other tutor or other resource. So this is all my own material that I put together. So without further ado, let's go ahead and jump in. These are the topics we'll be covering today: torsions, endometriosis, adenomyosis, PCOS, and ovarian cyst. Um, I'm going to do this in 10, I'm aiming for like 10 to 15-minute videos. We'll see how it goes. I'm just going to kind of roll things out piece by piece. And if it gets good feedback, I'll keep doing it. But yeah, and if you're interested in tutoring at a reasonable cost, feel free to reach out to me. My email will be in the link in the description. And otherwise, follow and subscribe. I really am not too sure about how this platform operates. But if you subscribe, I think that's supposed to be helpful. So at least you'll know when new things are coming out, I think. So, and I'm going to try to do at least 2 to 3 uploads a week. So let's go ahead, dive in, and these will not be in order. I made the mistake the first time I recorded of doing all these things in order, so that became a little too predictable. All right, let's jump in. So I'm going to give you about 30 seconds to go ahead and look at this, and then I'll kind of read into it, and then we'll go from there. And feel free to pause the video if you need to, but let's go ahead and dive in. When I'm tutoring people, you always read the last sentence first. So what's the next best step in diagnosis? And then you kind of go through the answer choices. Okay, so coming in as a 25-year-old female, she's had difficulty getting pregnant. So that's her chief complaint's been going on for 14 months. And so that is a legitimate problem. If it's anything less than 12 months, it's not as much of an issue. They just need to keep trying. She's sexually active with one male partner, unprotected intercourse, and her husband had normal semen analysis. We know he's not the problem. And she's also having pelvic cramping prior to menstruation, increased severity of her menstrual cramps, not improving with NSAIDs, and history of chronic pain with intercourse, as well as pain with defecation. All right, so right off the bat, this is going to quantify or qualify as what I call the 4Ds. So dysmetria, dyspareunia, dysmenorrhea, dyskesia, 4Ds. That's what I think of when I'm thinking about endometriosis. All right. And so endometriosis is most likely diagnosis here. She also has trouble getting pregnant, so signs of infertility. And so that strengthens what we're thinking. And her problems haven't improved since. So they've already kind of done the first step here, kind of. However, there's something you need to do in the diagnostic pathway, though. All right, so whenever we're talking about diagnosis and treatment, so there's diagnosis, there's treatment, and then there's management, which sometimes blends the two together. Here, we're just talking about diagnosis. First thing you're going to want to do is you're going to want to do a transvaginal ultrasound. And are you looking for anything on transvaginal ultrasound? What are you going to see? Likely, you're not going to see anything. If you see something, the only thing you're going to see is a endometrioma. or your chocolate cyst. If you see that, you can diagnose endometriosis. Otherwise, if this is endometriosis, we're not going to see anything on the transvaginal ultrasound, right? So that's the first step. Now, hysterosalpingogram, that's going to be used if there's adhesions, if there's fallopian tube problems, so less likely to be that. XLAP, that's going to be the last step in management for endometriosis, and combined OCPs would be a step in treatment, not a step in diagnosis. And then an abdominal CT is not going to show us anything with endometriosis. You can't see it. So transvaginal ultrasound. So the diagnostic pathway is going to be ultrasound, then you do your NSAIDs and OCPs, and then after you do your NSAIDs and OCPs, then you do your XLAB if they're still not improving. And if you do an XLAB and you see the implanted endometrial tissue, then you go ahead and remove it, and that's your last step. So endometriosis, they want you to know pathophysiology. So ectopic implantation of endometrial glands into the peritoneum. Most common theory, this will show up. The retrograde menstruation theory is the most common theory that we have. Normally everything flows downwards, instead things flow backwards out through the fallopian tubes and into the peritoneum. On exam, or clinically, you're going to see dysmetria, dysmenorrhea, dyspareunia, dysesthesia, and then they might have infertility or just chronic pelvic pain as well. Physical exam symptoms are going to be related to where the endometrial tissue implants, right? So if the endometrial tissue implants into the rectovaginal area, then you're going to have pain of defecation. If it implants into the ureterosacral ligaments, then you're going to have pain with cervical motion tenderness, or you're going to have cervical motion tenderness. As far as managing this goes, you're going to start out with transvaginal ultrasound, then you go to your NSAIDs and OCPs, and then you finish with your XLAB, with or without resection, depending on if you see those ectopic endometrial glands. And remember, you can only see an endometrioma on transvaginal ultrasound. So likely when we do our ultrasound, we're ruling out other things. And if it's negative, we go ahead and we treat. And if they don't get better, then we do the most invasive thing, which is our XLAB. All right. And if you have questions about any of these things, put them in the comments and I'll try to answer them. So, all right. So moving along, now go ahead and read this one. I'll give it another 30 seconds. So you can go ahead and pause if you need more time. But so now we're asking about what labs are going to be shown or what labs can be elevated. So looking at the answers, all right, 21-year-old female, history of obesity, acne, and she's been having difficulty getting pregnant with her husband despite trying without protection for the past 13 months. Okay, similar problem. Physical exam, you notice dark hairs on the chin, and she's been losing hair. Her last menstrual period was 2.5 months ago, and otherwise, she says it's been normal. She's had normal periods over the past 2 years. So what lab size can be elevated? So this woman, obesity, acne, and difficulty getting pregnant, and hirsutism, right? So this makes me think about PCOS. And so PCOS, you're going to, what are we going to see? Well, we know that we're going to see an increased LH FSH ratio. And so our FSH is actually going to be lower. 17-hydroxyprogesterone goes with congenital adrenal hyperplasia or the non-classic congenital adrenal hyperplasia. Vanilla, maleic acid, I apologize if I misspelled that. There might be typos in this. I apologize. But vanilla and maleic acid, we expect that as part of our plasmaminonephrin with pheochromocytoma. And so cortisol and testosterone. Testosterone is definitely going to be elevated. Estrogen's also going to be elevated, but remember, it's more likely to be estrone, and estrone is the one that gets aromatized at the fat tissue because of the obesity, and estrone is probably the weakest of the estrogens. So we're going to go with testosterone here. So PCOS is another one, another huge favorite as far as the guide material goes. You're very likely to get this on your shelf or even on Step. I'm certain I got this on Step. I don't remember, but I'm pretty sure I got this. So big things, you're gonna have menstrual irregularities, obesity or insulin resistance, and hirsutism. Other coexistent stuff that can happen, type 2 diabetes, it's a big one. So you want to put these people on metformin, and they can also have pregnancy loss and endometrial cancer. Now, the way to diagnose this, and I always tell my students, be systematic. So, best way to diagnose this is going to be Rotterdam criteria and knowing that you need 2 out of 3. So, changes in ovulation, either illegal ovulation, changes, or anovulation where they're not ovulating at all, and hyperandrogenism, signs of hirsutism. So here it was like the hair on the chin, and polycystic ovaries on ultrasound. Transvaginal is going to be much better than our transabdominal, and you confirm this with an elevation in testosterone or an increased LH-FSH ratio greater than 2 to 1. Treating this, you're going to start with combined oral contraceptives. The combined oral contraceptives will also fix the endometrial hyperplasia, they'll fix the menstrual bleeding, they'll also fix the acne. So it'll decrease the amount of androgens that we're having. If we have less androgens, we're going to have less of these problems. Metformin will help with the metabolic symptoms. It can also help with weight loss as well. Remember, your most common side effect of metformin is going to be diarrhea, and your most feared side effect is going to be lactic acidosis. Lactic acidosis can be more common in people with renal disease, and lactic acidosis is also the reason we don't use metformin as first line for gestational diabetes. So if you have a patient who's pregnant and they develop gestational diabetes after that 20th week of life, then you want to start them on insulin therapy. Then you want to use letrozole, an aromatase inhibitor, if you're trying to induce ovulation. This always has had a confusing mechanism to me, but basically we inhibit aromatase, and then it's going to basically kind of stop this entire HPG axis and allow it to restart, and so that can stimulate FSH production again. So, moving on, go ahead and read this one. Let me know what you're thinking, and then I'll give you 30 seconds again, and then we'll dive back into it. All right. So diving into this one, so here I kind of splice things up. So what's the most likely diagnosis here? We have a 19-year-old female